It's a good time, though, to bring in our favourite Labour MP, the Member of Parliament for Taieri, opposition Member of Parliament for Taieri, Ingrid Leary. Ingrid, welcome to the show. Hey, and how's David Parker getting on? Because he can't be well if he can't get sworn in.
I think there were plans to swear him in off-site, and part of the reason that didn't happen was to do with the technical rules of Parliament and where swearing-ins can happen. I did visit David Parker when he was in Dunedin Hospital. He was pretty stoic, said it wasn't too bad, and then I saw the x-rays of the fracture and we all went, ouch. I'm sure he's following lots of politics, reading lots of books, and probably reacquainting himself with his Foreign Affairs spokesperson portfolio.
Is that actually, which portfolio were you given, Ingrid?
Seniors and mental health, two of which I asked for. Seniors is a really good fit with my electorate. We've got about 25% of the electorate are over the age of 65, and mental health is something dear to my heart. I'm a fellow of the Mental Health Rosalind Carter Centre in the US, where I did a lot of work around destigmatising of mental health reporting. So very keen on those two portfolios.
Actually, I suppose it's a good question to ask you. You would have seen the articles in the last 48 hours, 24 hours, related to mental health and the funding of. In 2019, it was I remember it being a big factor just prior to COVID, so obviously there's a post-COVID, but the Labour government committed an unprecedented 1.9 billion New Zealand to improve mental health services. But 4 years later, it's been reported that those high hopes have not been realised, largely in good part due to an inability to recruit the workforce. Is that your understanding as well?
I think first you have to appreciate that when we got into office, we started at zero. The funding levels under the previous national government had dropped to around 35% of what the demand was for mental health services. There had also been a major review that was initiated by my colleague, Honourable Dr. David Clark, which said very clearly that mental health services should be focused much more significantly at the prevention and primary health care level in order to get better mental health outcomes, and that hadn't been happening. So what this government did was create that system, and indeed workforce problems became part of it. It was also part of what we were looking to build up. COVID happened, which was really difficult, along with other issues that meant that the workforce development couldn't happen as fast as possible. But if we look at what the Mental Health Foundation has called for, the three pillars that will make the mental health system strong, they say are prevention, services and workforce. If we look at prevention, that's all those things that the last government did around the impacts of colonisation on Māori, around family violence, poverty, housing, and so on. So take, for example, impacts of colonisation. We've seen that through outcomes for Māori health. We set up the Māori Health Authority that's now being disbanded. We had the Sexual and Family Violence Minister, the first time there's been a minister in that area. So there's a lot that we did do, and when I read those articles, I get that the CEO of the Mental Health Foundation, his job is to push for more and better, but actually there was a good level of delivery.
I think the argument, from what I can see, Hilary, is that the money was there, it's just that the delivery was poor. So, for example, the article I read prior to looking at this morning was from Victoria University's Dougal Sutherland, who's a clinical psychologist there. And I don't know if you're aware of it, but his in conclusion was that looking at our mental health system in 2023, it feels that very little progress has been made. A blinkered approach to how to spend the $1.9 billion of our health dollars has stymied any good intentions that behind the original plan. Is that criticism fair?
I don't think it is. I mean, if we look at Access and Choice, which is a program that started in 2020, we delivered 998,000 counselling sessions that focused on mental health and addiction in particular. Yes, it hasn't reached the targets, but it's on a great trajectory. It's a very ambitious program, and it will get there over time. So what I'm hoping that the new mental health minister will do is allow the things that are working to keep going. Don't start dismantling things, assuming they're not working, when actually it's going to take a little bit of time. I think workforce issues have been a problem, but we freed up a huge number of people to be able to opt into registration for counselling services. We just need to give it the time to actually bed down. We've got to remember that we started with zero. This was a whole sector that had never been developed, and these things do take more than one term.
Can you tell me how the impacts of colonisation, I mean, given that it's 173 years since the Treaty of Waitangi being signed, affect Māori mental health in 2023?
I think that one of the big determinants, and there's a lot of evidence to show it, that is correlated to poor mental health is poverty. So when we look at the post-colonisation experience of Māori, they are overrepresented across all the data groups that link to poverty, poor housing, poor nutrition, lower life expectancy. So it's not being Māori per se, it is the impact that colonisation has had on a group of New Zealanders, where they have now formed the bulk of the deprivation statistics. The same equally could well be said to apply for many of our Pacific families.
Right, so your argument is not necessarily that they're mentally ill because they're Māori, they're mentally ill because they're poor.
They don't have the same mental health outcomes, and I would say part of it is because they're poor. There are also the impacts of things. Say, let's look at the current debate. When you have a government that's dismantling a focus on Māori language and sending messages that many Māori are interpreting as saying that they're second-class citizens, that undoubtedly has an impact on mental health, and we're hearing that in media stories from the parents of the kids who are being sent those messages. So there is an ethnic component to it. It's not the cause of it, but everything happens in a cultural context, and if people are feeling attacked, then that is part of it.
So, in other words, if I'm in a Māori culture and I'm receiving a message that I am being discriminated against, that might mean that I end up with what? A clinical form of depression, some form of schizophrenia, I don't know, ADD, ADHD, the whole series of psychological and psychiatric conditions here. I'm struggling to see the connection, because in many of the psychiatric conditions, I would have thought, Ingrid, and I mean, this is your mental health area, but that these are chemical problems, they're not cultural problems.
Well, that's not what the Mental Health Foundation is saying. They are talking about the prevention as being one of the three pillars, and if we apply it with a different lens, say to the rainbow communities, there's a lot of data to show that rainbow communities have significantly higher levels of suicide attempts and completed suicides. And the messages coming from those communities are because of social exclusion. There is a clear link, and what you're talking about, I think, has more to do with prevalence. And I absolutely agree with the Australia-New Zealand Royal College of Psychiatrists, who are saying what we still need, what hasn't been done, and this is what I would be calling on Matt Ducey to make sure happens, is a prevalence, a baseline, so that we can understand who is not able to access in-house services for those things that you've identified, such as schizophrenia, bipolar, those that are related to what you would say is chemical imbalance, although I have to say there is new practice and accepted practice to show that schizophrenia is also can be trauma related, and that trauma can come from poverty and from sexual and family violence. So it's a complex area. But we do need the baseline data on prevalence as well. We definitely need to keep focusing on workforce development.
Sorry, I worked in this area. I was a clinical assistant to Professor Basil Janes at the Department of Mental Health in Otago University for a couple of years during my university times. And one of the clear signs of that was, I remember, was suggesting that there were these people who were suffering had clear chemical problems. In other words, there was an absence in their brain of particular neurons or chemical functions that caused to a large extent schizophrenia, bipolar disorder, clinical depression as compared to the cultural depression, ADHD, autism, etc. Those aren't cultural issues, are they? What you're trying to say to me is that, well, they could be exacerbated by cultural tradition. Is that what you're saying to me?
Well, they could be. There's two responses that I have. One is they could be, and there could be other co-factors, such as then the use of, say, cannabis or alcohol as a self-medicating kind of thing. But I am aware that certainly in the field of schizophrenia, the question about why those chemical changes happen, there is now emerging evidence to show that the neuroplasticity of the brain does respond to trauma and to context, not just to genetics. And so if someone is in a traumatic situation, say in an extremely traumatic childhood, there might be abuse and so on, there can be a diagnosis of schizophrenia that has not presented in that lineage of family that they are now attributing to that. So it's all
listen, I don't disagree with you. I don't disagree with you, but it's just that I guess I'm struggling with just the concept that that's Maori. I mean, the kind of deprivation you're talking about and that kind of appalling abuse. Gee, the clinical people that came into Basil James's private practice, they were a wide variety of ethnicities, Ingrid.